Good afternoon, everybody. This is Dr. Kachikian from the Black Hills Eye Institute, and today we have a routine cataract case. This is a case I just did recently, and I thought I'd go through it. We first make a side port, and I try and go in parallel to the iris with the side port slightly angled down, um, but sometimes the more you angle the side port, the more it tends to leak when the case is over. A little bit of BSS in the anterior chamber with omidria to try and dilate the pupil a little bit more, and then viscoelastic. Put the viscoelastic in and just kind of one wave to get a good, complete feel of the anterior chamber. And then I would usually mark the surface of the cornea with a I think it's a 525 millimeter marking ring. And then I'll make a main incision. I use the fixation ring with the spikes pointed up to not cause any damage to the conjunctiva. And then I enter very slowly with a 2.4 millimeter blade. I tend to make a single plane incision because I really do feel that it seals better than kind of a triplanar incision. I also like the configuration of the single plane incision. We start a capsular axis with the Utrata forceps, and I try and follow the edge of the pupil in this case. I do try and keep it approximately the size of the mark that I made, but the mark is not always central, so I try and use the size of the mark, but also follow the edge of the pupil to keep the capsular axis centered. We then will do some hydrodissection and hydrodelineation with BSS. I use just a 27 gauge cannula because I feel that seems to work the best in my hands. I never really got the hang of the Chang cannula. Once the lens rotates, you've got your hydrodissection, and then I usually will bury the 27 gauge cannula and do some hydrodelineation and spin the lens at the same time to ensure that we get good 360-degree hydrodelineation. We reinflate with some viscoelastic to make sure that the endothelium is covered, and then I'll check the flow through the phaco handpiece and make sure there's good and balanced flow of the BSS. And then I go into the eye, and I usually will start on quadrant mode to clear the tip of the phaco handpiece. Once it's clear and I remove some anterior cortex, I begin to sculpt. I'll sculpt 2 or 3 times to get deep enough to create a central groove and crack it, and then I'll use the second instrument and the phaco handpiece to crack the lens, and usually I'll do a stop and chop. I'm usually in foot position 0 when I do my chop because I feel it gives plenty of room for the chopper. And then I remove that first piece of lens. If you're in foot position 2, or 1 I should say, and you try and place the second instrument behind the lens, sometimes it's a little too tight. There's a little too much pressure in the anterior chamber. And so I usually will go into foot position 0 and then manually place the chopper behind the lens equator. We have removed all of our quadrants now. There's the last quadrant just coming out. Again, we try and keep that phaco handpiece almost in the bag. I don't really try and emulsify the lens in the anterior chamber. I try and emulsify it with the handpiece still in the bag, being careful with the second instrument to make sure that it's placed behind the lens to ensure that there's no trampolining of the capsule. Now we are removing our epinucleus. Some people believe it's kind of a waste of time to remove the epinucleus, but I do think it protects the capsular bag until you remove the central nucleus, and then the epinucleus comes out fairly easily. Now that we've got our epinucleus removed, we're going to use the IA handpiece to remove the remainder of the cortex. I don't have a routine way of removing cortex. I kind of see what looks like it's going to come out easily, and I go that way. There you can see this piece didn't come out, so we move along to the next section, and lo and behold, the remainder of the cortex comes out on that side. Then we're going to kind of sweep. I do use a sweeping motion to remove the cortex, try and get some subincisional cortex here, and just grasp just under the capsular rim and sweep to loosen up the cortex and pull it. You'll notice the instruments, they tend to remain fairly central throughout the case, both the phaco handpiece and the eye handpiece as much as possible. And then we'll remove a few remaining strands. And then typically I will power wash the capsule with some balanced saline on a 27 gauge cannula just to get any remnants off of the back of the capsule, minimize the posterior capsule opacity perhaps. Then we will reinflate the eye with our Provisc. And usually I will polish that anterior capsule with a sweeper. In cases like this where you can barely see the edge of the anterior capsule given the size of the pupil, I don't always do it, or I do it very gently. I don't really want to liberate a lot of iris pigment, but just remove that little remaining lens material from the anterior capsule. Usually there's a significant amount that comes off, more than you'd expect. Then we place the lens. This is an Alcon Auto lens and preloaded in the injector. Place the lens into the eye, stabilizing with the second instrument. And then I always use a Sinskey to get the lens in the position I want it and to help the haptics open up. I really don't like to complete the case while the haptics still haven't completely unfolded. I try and get the haptics at least off of the optic and have the optic mostly unfolded before I'm done. I always go posterior to the lens to remove any viscoelastic back there, and then I will peripherally sweep both superiorly and inferiorly to make sure all of the viscoelastic or Provisc is removed. Once I'm fairly certain that there's no viscoat in the angle, I center the lens, possibly give it one more sweep depending on that, and then I will reinflate the eye and seal the incisions. I do use the BSS again to irrigate the angle to make sure there's no remaining lens pieces or viscoelastic in the angle, and then I'll hydrate the incisions. We do use some intracameral moxifloxacin at the end of the case to ensure or try and minimize any risk of endophthalmitis. So I will usually put a little bit of that in, and then typically reinflate the eye and check the incisions to make sure they are well sealed. I use a WEC to do that. And the case is complete. Now in this case, what we are going to do is we are going to place a Dextenza in the punctum. I do kind of like the Dextenza. It seems to work pretty well and go in pretty easily. There's the punctum. I will dilate the punctum with the punctal dilator. I really do push pretty hard. The patients don't seem to feel it very much. I use the narrow end and then the wide end. The wide end looks very wide, but it tends to dilate the punctum very well as well. Once it's been dilated, we will try and make sure it's relatively dry and then grab the Dextenza. If the punctum is really wet, then the Dextenza expands fairly quickly and it becomes more difficult to get it in. And you'll actually kind of see that here. I grab the Dextenza with the forceps and place it in the punctum, and usually I'll grab it more vertically than that. I kind of grasp it perpendicular, and I try not to do that. Usually I'll grab it more vertically. As you can see, it has swollen, and now it's hard to get in. And if this is the case, I will typically give it a few tries and then transition to a 0.12 forcep, which can get a better grasp of the Dextenza. Grab it and shove it in, and there it goes. And if you have dilated well enough, it goes in fairly easily, and the case is over. Thanks for watching.